is by our Korean colleagues, Dr. Eui-Cheol Shin from Korea Advanced Institute of Science and Technology at Korea. And I think this is a very interesting topic connecting to the last excellent talk. TNF-producing regulatory T cells as in viral hepatitis, so we need to know how you negatively regulate the T cell response in hepatitis B.
Yeah, thank you. And thank you for giving me this opportunity to present our recent work in this meeting. So today, I'm going to talk about the regulatory T cell, Treg cell, in viral hepatitis, but particularly a not conventional Treg cell, but TNF-alpha producing Treg cell. As you know very well, CD4, CD positive, CD25 positive, FOXP3 positive regulatory T cell, so-called Treg cells, suppress the activation and proliferation and effector function of many types of immune cells, particularly T cell. So they contribute to immunological tolerance in the many kind of situations. So now the figure is showing the differentiation of CD4 T cell to the different types of the effector T cell, including helper 1 cell, helper 2 cell, helper 17 cell, and more Treg cell. But initially, we thought that if they once differentiated, then they have their function with this kind of the differentiated status without any plasticity. But later, the many scientists, they reported that they can, flexibly, they can be converted to other types of T cell. So in the case of Treg cell, so the figure is showing that after once differentiate to the Treg cell, depending on the cytokine microenvironment, they can acquire TBET, and the hallmark of the Th1, that at the same time they can exert helper-like function. So now, in the CD4 T cell differentiation fields, now we believe that this lineage plasticity or flexibility they exist, and depending on the cytokine microenvironment. So in fact, since the 7 or 8 years ago, so in humans, inflammatory disease or autoimmune disease, this lineage plasticity of Treg cell has been reported. The helper 1 like the Treg cell, it means that interferon gamma producing Treg cell, it was initially reported in the multiple sclerosis patient. Not only this multiple sclerosis patient, an IDDM, type 1 IDDM patient, they also have the helper 1 like Treg cell. But not only the helper 1 like Treg cell, the helper 17 like Treg cell has been also reported. So this Treg cell produce IL-17, so especially in the case of inflammatory bowel disease and psoriatic skin disease. So this is just one of the examples of the IL-17A producing. It means helper 17 like Treg cell. In the microenvironment enriched by IL-1 beta, IL-6, or IL-23, the conventional Treg cell, so they can acquire the little bit of the ROR gamma expression. At the same time, this signal can suppress the expression of FOXP3 a little bit. And then, as a consequence of down-modulate FOXP3 and upregulate ROR gamma T, they can produce IL-17A. So it has been also well known that, so not only psoriasis, inflammatory bowel disease, but in HBV infection and in some cancer patients, this kind of IL-17A producing Treg cell was reported. So today, I'm going to talk about this kind of the lineage plasticity of Treg cell in hepatitis viral infection, including HIV, HBV, and HCV. In my talk, but mainly I will focus on HIV infection and HCV infection, particularly after DAA treatment. So in my study, so we defined the Treg cell with a very strict the definition. So not only CD4 positive, 25 positive, FOXP3 positive, this marker, but also we applied the CD127, the low marker, because in human T cell, effector T cell, non-Treg cell, they can transiently acquire FOXP3 expression during the activation. So to distinguish the real Treg cell and the transiently activate non-Treg cell, they use the CD127 low, this marker. So this is an example of our gating strategy to define the CD4 positive, 25 positive, 127 low, FOXP3 positive Treg cell. So at the beginning, so we started this project. So when we studied the HIV infected patient, the patient with acute hepatitis A. So several years ago in Korea, in South Korea, there's some small epidemic of this acute hepatitis A. And during this epidemic, we acquired the peripheral blood lymphocyte from patient, the whole blood. And we stimulate this the peripheral blood lymphocyte with this anti-CD3 and CD28 antibody. And then initially we studied the helper-like phenotype or helper 17-like phenotype by observing the interferon gamma production from Treg cell or IL-17A production from Treg cell. But we surprisingly found that rather than interferon gamma or IL-17A, TNF-alpha production was very prominent in this patient Treg cell. As you can see here, in the healthy control donor, there's not so much interferon gamma IL-17A TNF-alpha production. But in the acute Hep A patient, interferon gamma or IL-17A, the production is a little bit observed, but very prominently, the TNF-alpha production was observed from this Treg cell population. So this is case from the single patient, but this is showing the statistical difference between the healthy donor and acute Hep A patient. As you can see here, in the acute Hep A patient, upon anti-CD3 CD20 stimulation, they produce a lot of TNF-alpha. So also at the same time, interferon gamma IL-17A production was a little bit increased. So in the previous slide, I showed you that the TNF-alpha production from Treg cell by using the peripheral blood lymphocyte. In this time, we acquired the liver-infiltrating lymphocyte. We obtained the liver-infiltrating lymphocyte during the liver transplantation of acute Hep A patient. And also in the liver compartment, the Treg cell can produce TNF-alpha upon anti-CD3 stimulation. But then, what is the kinetics of this kind of the unique population? This one is showing the course of this acute Hep A from 5 patients. If I'm showing this one single case, in this patient, at the admission due to the acute Hep A, the ALT value was 9,900, very severe liver damage. In that time, the TNF-alpha production was observed in near 20% of Treg cell. But 6 days later, the ALT, the value was dramatically decreased to the 300, then near normalized the TNF-alpha production. And 1 month later, when ALT was really normalized, the Treg cell, the TNF-alpha positive Treg cell was not so much observed in this stable stage. So with this data, we conclude that maybe the TNF-alpha positive Treg cell, they are present during the disease status. After resolution from the disease, there's no more this kind of phenotype from Treg cell. And also, in acute Hep A patient, so there's nice correlation between the percentage of TNF-alpha positive Treg cell and the serum ALT value when they admitted to the hospital. So it means that we don't know yet this is cause of liver injury or the consequence of liver injury. But anyway, so we could guess that from this data, this TNF-alpha production from Treg cell has some of the role in the immune-mediated liver injury during the very acute the viral hepatitis. Then next, we move to the other types of viral hepatitis. Then, how about in HBV infection or HCV infection? At this stage, we recruited more patients with acute HBV infection and chronic HBV infection, acute HCV infection and chronic HCV infection. Then statistically we found that in the chronic HBV infection and chronic HCV infection, there also increase of this kind of TNF positive Treg cell in the peripheral blood lymphocyte. In the case of acute HBV and acute HCV infection, so if we increase maybe the number of patients, we may see this kind of the increase, but at this stage, we could not conclude about acute HBV or HCV infection. Then, now I showed that this kind of very unique TNF-alpha positive Treg cell population can be seen. So not only in acute hepatitis A patient, but also chronic HBV or HCV infection. Then how about their molecular characteristics? So maybe many of you will ask about this question. Are they really Treg cell or not? Maybe they are just activated non-Treg effectors. They're not real bona fide Treg cell. To answer this question, so we studied the Treg-specific demethylated region. It means that in the Treg cell, the upstream of FOXP3, the gene, they have to be demethylated. In contrast to Treg cell, the non-Treg cell, they have a hypermethylated the TSDR region. So we sorted our patient T cell, TNF-alpha positive, the FOXP3 positive CD4 T cell, TNF-alpha negative FOXP3 positive CD4 T cell, and non-Treg cell, FOXP3 negative CD4 T cell. As we can expect, in the non-Treg cell, all of these TSL regions are hypermethylated. But in this, the TNF-alpha negative or positive, the FOXP3 positive, the Treg cell population, there the TSL region is almost demethylated. Especially TNF-alpha positive, the FOXP3 positive CD4 T cell, all of these regions are demethylated. So with this, the result, we could conclude that these TNF positive, FOXP3 positive CD4 T cell are real bona fide Treg cell, not the non-Treg activated non-Treg cell. Then how about their molecular characteristic? Now we analyze the T cell transcription factor or the chemokine receptor in this cell. In this, the patient, TNF-alpha positive Treg cell and negative Treg cell, compared to TNF-alpha negative Treg cell, the TNF-alpha positive Treg cell, they have upregulation of Tbet. Tbet is the hallmark of the helper 1. The phenotype, and GATA3 is the helper 2 transcription factor, but it's already well known that for the stability of the Treg cell, GATA3 is required. But in the case of TNF positive Treg cell, GATA3 was downregulated. At the same time, they acquired ROR gamma T expression. ROR gamma T is the hallmark transcription factor, master transcription regulator of helper 17. At the same time, in the chemokine receptor, they overexpress CCR5 and CCR6. Especially CCR5 is well known, the chemokine, the receptor, which is the receptor for RANTES of ME1 alpha and ME1 beta. All of this chemokine ligand is well known to be induced, upregulated during the viral hepatitis. So due to this ROR gamma T expression, overexpression, we analyze the TNF positive Treg cell for their phenotype for IL-17A production. So the TNF-alpha positive Treg cell, they tend to produce more IL-17A compared to the TNF-alpha negative population counterpart. At the same time, so we could confirm that among these TNF-alpha positive Treg cell, this IL-17A producing Treg cell, they are ROR gamma T double positive. So all of these data indicating that these TNF-alpha positive Treg cell, they exhibit helper 17-like feature in terms of transcription factor, ROR gamma T, and in terms of their function, IL-17A co-production. So with this data, we want to modulate the function of this TNF-alpha positive Treg cell. Because they overexpress, they have upregulation of ROR gamma T expression, we use ROR gamma T inhibitor. So there's some of the pharmacologic inhibitor for ROR gamma T, so not yet clinically approved yet, but we can use those the inhibitor for in vitro experiment. And then by applying this ROR gamma T inhibitor, we could downregulate the TNF-alpha production from Treg cell. And not only TNF-alpha production, but also IL-17A production could be down-modulated by this ROR gamma T pharmacologic inhibition. So let me summarize my first part of my talk. And during the viral hepatitis, including HIV infection and chronic HCV infection, we could find that the Treg cell can produce TNF-alpha. And this cell has the upregulation of ROR gamma T, the upregulation. And although I didn't show you, FOXP3 expression is a little bit downregulated, although still they express FOXP3. And they have the reduced suppressive activity. And this the value correlates with the liver injury. In the second part, I'm going to show you what will happen in this TNF-alpha positive Treg cell population during and after DAA treatment of chronic HCV infected patient. So now I'm showing you again the Treg gating strategy. And in this study, in this part, we recruited the number of 29 patient, DAA treated patient. Among them, 19 patients treated with the DCV and ASV, and 15 patients treated with SOFSV and LDV. And now I'm showing you the Treg frequency, the before treatment and after treatment, week 8, week 12 or week 16. And after cessation, after stopping of the DAA treatment, 12 weeks later, we also we obtained the whole blood and we measured Treg cell. And when we measure the frequency of Treg cell, there's not so much the change in this, even before and after, during and after DAA treatment. But how about the TNF-alpha positive Treg cell? So in the baseline, the before treatment, we confirm again that compared to healthy control donor, this the chronic hepatitis C patient, they have increased frequency of TNF-alpha positive producing Treg cell. And then what will happen after DAA treatment? At the baseline, for example, now you can see in this single patient, 6% of the TNF production. But after starting DAA treatment, week 8, the percentage decreased up to 3.9%, and week 16 again 4%, 7%. But after stopping the DAA treatment, 12 weeks later, the percentage will increase again up to 8%, 8.1%. So now I'm showing you all this, the 29 patient data here. So now I can say that, I can conclude that before DAA treatment in the chronic HCV infected patient, they have increased frequency of TNF-alpha positive Treg cell. But after starting the DAA treatment, initially it seems that transiently the frequency of the TNF-alpha positive Treg cell, it transiently decreased. But after stopping the successful after DAA treatment, they achieved SVR. But so the frequency of TNF-alpha positive Treg cell, it increased again, and then it was not normalized, even after successful DAA treatment. So we don't know yet the clinical significance of this phenotype. But anyway, so the student, he asked about this question. And then, maybe possibly before and after the DAA treatment, although the frequency was not so changing, not normalized, how about the phenotype, the molecular phenotype? But there's no change in means. This is before treatment and after treatment. So after treatment, the TNF positive Treg cell, they still overexpress ROR gamma T and CCL6 and IL-17A. It means that at least, so although they achieved the HCV clearance, at least in terms of the TNF-alpha positive Treg cell, the phenotype, it was not normalized even after HCV clearance. So we don't know yet the reason why, and we don't know yet the clinical implication of this the phenomenon. But anyway, now I can show you that. So this one is the helper 7, the normal Treg cell, and helper 17-like TNF-alpha producing Treg cell. So there's some of the molecular signature. But after, in the chronic HCV patient, after DAA treatment, transiently, it seems to be normalized. But after successful treatment, it returned to the TNF, the Th17-like TNF-producing Treg cell phenotype. So as the next step, now we are studying the clinical implication of this kind of the TNF-producing Treg cell in successfully DAA-treated HCV patient. So in my lab, so we are now studying the HIV infection since 9 or 8 or 9 years ago, since when the HIV infection epidemic occurred in South Korea. Since that time now, we are doing the nationwide collaboration with the clinician, and owing to the help, we could produce this kind of the immunological detailed mechanism study. Thank you for your attention.
Any questions from the floor? We have one question.
Thank you very much for interesting topic. You showed that TNF-alpha producing regulatory T cells in HIV. Do you have evidence that those T cells actually regulate the effector function of CD8 T cells or other immune cells?
Actually, I didn't show you yet. I didn't show you in my talk, but we performed a suppression assay. Okay. They could exert suppressive activity still, but suppressive activity is a little bit decreased. Okay. So initially, we hypothesized that maybe TNF-alpha, they can suppress, inhibit their suppressive activity. Right. So during the in vitro suppression assay, we added neutralizing antibody for TNF-alpha, but there's no change. So not due to TNF-alpha.
So you don't know which molecule is actually suppressing the immune response. Yeah.
But the FOXP3 level is a little bit decreased. So due to this, the down modulation of FOXP3, or every aspect of the Treg cell function, we guess that it's not just one single factor.
Okay. Yeah. The similar thing is, do you know if the IL-17 induces TNF-alpha?
Actually, we don't think that, because we once add the neutralizing antibody virus 17A, it doesn't change the TNF production.
Okay, thank you very much.
Wow. We have another questions at the back.
Thank you, Eui-Cheol. And very nice talk and fantastic work. And Kanto from Japan. I'm just wondering about the lineage, about the TNF-alpha positive Treg cells. So you talked about the pattern of maturation of the region of FOXP3 and clearly showed that that is the hypomethylated TNF-alpha positive Treg cells. Do you think that is coming from the thymus? And after that, in the peripheral tissues that is converted to the Th17 or TNF-alpha positivity and still have the suppressor effect you mentioned like that.
Yeah.
So do you think so?
So at this time, I don't have the answer for your question, but I have the future plan. The one is the NGS, the next generation sequencing of a whole genome sequencing. By doing that, we can detect just not meaningful the somatic mutation. By measuring the analyzing somatic mutation, we can restructure, reconstitute their lineage. They are very similar to the regular Treg cell, or they are very similar to the non-Treg cell or naive T cell. In that way, now we are doing this kind of somatic mutation sequencing. And second one, maybe also at the same time, in my talk, I just stimulate them with the anti-CD3 antibody. But once we stimulate them with the HAV overlapping peptide, and then the strength of the TNF production is much lower, but still we could observe the TNF production. So some of them have a HAV specificity. So maybe that can be one of the hints for your question.
And do you think that it is kind of regulatable by the dendritic cells by the hepatitis virus? Because you showed both hepatitis A virus and hepatitis C virus infection that increase in the TNF-alpha positive Treg cells. My question is, what is the change or the impact the hepatitis virus given to?
Yeah, we don't know yet. So, but already I showed that there's a nice correlation between the percentage of TNF-alpha positive Treg cell and ALT value. So now just we hypothesize that due to the reduced surplus activity, the effector function cannot be down-regulated. So that maybe that can contribute to the immune-mediated liver injury for the hepatitis. And maybe, but our second hypothesis maybe TNF-alpha directly produced from the Treg cell, they can contribute to the liver injury. But so we just abandoned the second hypothesis because among the whole amount TNF-alpha in this body, Treg originated one is very, very small. We guessed that. So maybe first hypothesis may be more suitable for that question.
Thank you.
Yeah.
Any further questions? In fact, I have questions about the DAA's treatments. You have two groups of patients, one treated with the Bristol-Myers combinations with asunuprevir, with the protease inhibitor, and another group is Havani. So do the two patterns differs with the protease inhibitors?
Actually, so in our data, so
the curve is a little bit different.
Yeah, a little bit different. Now we are expanding the number of patients, but we just conclude that there's not a big difference depending on the DAA regimen. So we have a PBMC from the previous cohort, interferon treated patient. Surprisingly, in the case of interferon, with the interferon treated patient, there's no this kind of the reoccurrence of TNF-alpha positive Treg cell. In the case of interferon treated patient, after SVR, this TNF-alpha positive Treg cell was not observed anymore. So the DAA and interferon difference only.
Okay.
Right. Yeah.
Yes.
May I ask one question? In the first part of your presentation, you showed that the viral replication, hepatitis virus replication is related to the emergence of the TNF-positive Treg. But in the last part of your presentation, after DAA treatment, even after the elimination of hepatitis C virus, TNF-alpha positive Treg returns. So what is the mechanism of the emergence of the TNF-alpha positive Treg? I wonder that some kind of liver fibrosis or other kind of inflammatory immunological mechanism is related to the emergence.
Yeah, very important question, but very difficult question. So we guess that for the occurrence of the TNF-alpha positive Treg cell, the viral infection it induced. But during the chronic infection, maybe this cell has undergo some epigenetic change. So that's maybe the reason why they continue to produce TNF-alpha. So now we are doing some of the epigenetic study for those cells.
So the long-term chronic hepatitis virus infection causes epigenetic change of the lymphocytes.
Just a hypothesis. Yeah.
Hypothesis.
Yeah,
You
right.
showed that the maturation pattern of some genes. That gene is FOXP3,
FOXP3, right.
FOXP3 promoter region.
Yeah.
Oh, okay. Thank you. Are there any questions? Okay.
You think it's related to the durations of the infections to have these epigenetic changes?
Sorry?
The durations of the infections?
Oh, we don't know yet. Yeah, right.
That's,
Okay, thank you very much for your beautiful presentation. Now let's